All right, I think we'll get started. Yeah, welcome everybody. Henry Lee, I'm a neonatologist at UCSD. I'm part of the OASCN team, and I'm excited to help start off this webinar on the OASCN Collaborative and describing some of the antibiotic stewardship resources that were built as part of the collaborative. This is our agenda for our webinar. I'll start off just a few minutes just describing a little background and goals, and then we'll go over the OASCN um, Collaborative and some of the results, and talk about some lessons learned, and then go over the resource bundle that's already available on the CPQCC website. And then excited to have some of our OASCN participants talk about some of their experiences and what some of the lessons learned were during the project, and then we'll wrap up. Next slide. If you are wanting to get CE credits, and if you're an RN, please chat your name in, and you'll be able to get the credit. And I'll just start kind of starting off on a tangent a little bit, going over some of the accomplishments of CPQCC, and this is just a figure showing over the past decade or so how survival without major morbidity among VLBW infants has increased over time in California. And of course, there are many things that contribute to that, but us working together as a collaborative, I think I would argue is one major part of it. And on the bottom is a figure that, or a table that shows that even as the morbidities, survival without major morbidity has increased, even the babies who have morbidities, the number of morbidities has decreased over time, so that there are those babies who are experiencing fewer and fewer longer-term complications. Next slide. One of the major ways that we've tried to improve care in California through CPQCC is large-scale QI collaborative projects. And, this is not the topic of today, and it's a little bit of a tangent, but we had a collaborative on delivery room management, about 10 years ago. And what this figure shows is that there were some NICUs that participate in the collaborative. That's the solid line. And then there were some that sort of did their individual QI project related to delivery room. And then there were those in California that did not participate in either. And what this figure demonstrates is that it is the case that those NICUs that participated in the collaborative had the biggest improvement seen in things such as NICU admission hypothermia for preterm infants, and also an increase in CPAP and not intubated, which was a goal for this project. But it's also the case that the other NICUs in California also improved during the course of this time. And so I think that was encouraging, I think, finding that even those who aren't directly participating in these large-scale collaboratives are also, I think, benefiting just from the overall resources that are built and just being able to work together as a state. Next slide. And this is a figure from a paper that was written by Joe Shulman, CCS, who I think I really want to attribute his leadership in really helping us to start thinking about NICU antibiotic stewardship. Back when he actually led this data collection of antibiotic use rates across NICUs. And what this figure shows is that ultimately there's like a huge variation across NICUs in all different levels, regional, intermediate, community NICUs, that some NICUs had very little antibiotic use rates and some had very high. And I think what that pointed to was that there was room for more standardization and improvement. Next slide. And then just by collecting that data, what this figure shows is that over a course of a couple years, and this is going from A to D, is each year sort of the changing trend, is that you can see that the antibiotic use rates ultimately the variation decreased even over a couple years just by us all collecting these data together. And I think the previous antibiotic stewardship collaborative, which was held a couple of years ago, was a further step in trying to address this issue together. And then our OASCN Collaborative was sort of our next foray into trying to even do better in terms of learning about how to do optimal antibiotic stewardship. So with that, I think, I think so maybe two main points I want to just sort of start off with. One is we really learn so much by working together, even as we work across NICUs, that are in different regions across California, just by coming together in these collaborative QI projects, as well as these webinars, we have the opportunity to just really learn from each other. And so that's where I'm also excited again to hear from our participating NICUs, some representatives today. And then the second is really our group has been, our state has really been leaders in antibiotic stewardship for the whole country. I think just over the years, and I think this OASCN Collaborative again is demonstrating how hopefully we can all continue to learn together for this challenging issue. This is a figure showing all the participants, the 30 NICUs that participated in OASCN, and thank you to those NICUs who participated, and really all of the resources we were able to build came from this group. And really our OASCN Collaborative, even more so I think than previous QI collaboratives, was a learning together experience. So you'll hear more about that. So next I'll also thank the OASCN Faculty Panel. It's listed there, which again was a multidisciplinary group across the state who really helped contribute to the learning sessions and also the resources that you'll hear about today. So I'll hand off to Peter Mendel from the Lundquist Institute, who is one of our leaders, and I'm sorry, from RAND, and Peter from RAND, and excited to hear his overview of the OASCN results. Thank you.
Thanks, Henry. I'm not insulted by being associated with the Lundquist Institute, so Ken will be happy, but I am from RAND. And I want to just give an overview of how the OASCN Collaborative was unique and intentionally putting together, blending two different models of collaborative learning. So the first is an ECHO model developed and started about 10 years ago at University of New Mexico, which focuses on case-based learning, like going over patient cases, which clinicians normally are very engaged with, in a style of learning that's well suited to clinicians. High frequency meetings, maybe every week or 2 weeks, and broad staff engagement. So bringing in the whole care team to learn about how to improve care treatment for particular conditions. Compared to what a lot of people know from the quality improvement work, which is the QI or IHI collaborative model, which focuses on monitoring unit performance, looking at identifying system issues that can be fixed, and doing tests of change to improve those cycles. The team itself at the NICU or site level, unit level, meets regularly, but the collaborative itself might meet quarterly or a few times a year. But they both also share some real key principles together. One is the faculty panel that provides expertise on best practices and implementation, and helps facilitate the collaborative learning. A democratic, all teach, all learn philosophy that also values peer-to-peer learning as well as learning from experts. So we've really taken these two great tastes, our chocolate and peanut butter, put them together so that two great tastes that taste great together. If you go to next slide, Kristen. So what did this actually look like? What was the structure of the OASCN project? We started off with a half-day virtual kickoff. Year one was intensive collaborative with learning sessions every 2 weeks, and all the staff, clinicians and administrators, and other subdisciplines around the NICU were invited to learn all together. Then we went into our second year, which was 2022, which we met quarterly, and we had a final hybrid in-person and virtual closing session this past spring. As you can see, we also had our interdisciplinary faculty panel and a host of other ocean resources, including recap emails from each with learning points from each of the learning sessions that went out on the listserv. We had a share site for shared resources and archiving of didactics from the learning sessions, things that actually will be in the resource bundle that you'll be seeing later. And then I'll just summarize with Ocean by the numbers. So we had 29 NICU sites that went all through the collaborative, 182 learning session participants from Ocean sites, over 32 learning sessions across the 2 years. The sites themselves implemented 48 stewardship interventions, around 3 to 4 per site. And as you can see on the right-hand side, we've got the ARC, Agency for Healthcare Research and Quality, which supported this grant, allowed us to collect a host of implementation outcome data, which I'll just do a very quick reporting of our top line results, which are the average site AUR, antibiotic use ratio, across the collaborative. And you can see through the baseline year, which was 1 year prior to Ocean, to the intensive collaborative year, there was a large drop in total AUR of about 13.3%. That in the sustainment year continued on and at about and pretty much sustained at the same average mean site ratio for and both of those are statistically significant for overall 13% drop in AUR. If you go to the next slide, it gets a little more interesting when we look at breaking it down of AUR by gestational age. So for the term babies in our participating NICUs, we saw a huge, even larger drop of 26% change from the baseline to the first year. And then the sustainment year, it bumped up a little bit, but still statistically significant 18.5% change drop in AUR from baseline. So we're, and the last slide is looking at preterm AUR, which is very difficult to address, has different issues. As you can see, we had just a small and not statistically significant change from baseline to the first year, the intensive collaborative, but we did see quite a substantial and significant drop starting in the sustainment year. And a lot of that had to do with efforts that different Ocean sites started to perform and implement around preterm stewardship at that time, and also will be in the site talked about in the site presentations from our site participants. So with that, I will hand it over to Curlin.
All right, thanks, Peter. So one of the purposes of this webinar was to kind of pass on information to the NICUs that were not involved in Ocean, obviously advertise the resource bundle. You know, so the question comes up, what lessons can we pass on from all of this work, all of these numbers that Peter showed? How do we squeeze something useful out of this? So number one, you know, we found that measuring antibiotic use effectively and kind of innovating in this space can be really important. When the collaborative started, there were several NICUs that had challenges with capturing antibiotic use automatically. And so a lot of sites learned how to do this and figured out, you know, how to set this process up during the collaborative. And, you know, antibiotic stewardship is so fast paced. You're testing different changes. You're trying to figure out what's working in your NICU. And you don't want a 2 or 3 month lag waiting for, you know, your data analyst to send you information. So we found that if you can capture this automatically, figure out a system way to do that, and then actually automatically analyze this information as well. You see this control chart here of monthly AUR from one of the NICUs that basically shows you how you're doing every month relative to the past. And once you start using this, you can visualize this. Kristen, go back 1 second. So you can visualize this and market this very frequently to the group. And, a picture says 1,000 words. You look at this and you should be asking questions about these peaks and valleys in this data. And then if you're having trouble with making progress with your total AUR, one of the things that we found was that it's beneficial to stratify your AUR based on specific groups. And Sina Halayan, who's one of the neonatologists from Cedars, will touch on this during our Q&A. So number 2, so you can use this data and these control charts to engage everyone. One of the things we wanted to look into during the collaborative is engaging everyone with vignettes. So we use these case vignettes that we put together, kind of pragmatically looking to try to figure out and understand provider decisions. And we just found that it's really helpful to use these vignettes to engage a lot of people that might not be on the actual QI team that's involved in the stewardship work. We were able to objectively describe variation and quality and dig down into the drivers. And you don't have to do this as kind of a high-five method as we did. A lot of sites are using these methods, these vignette methods, these cases to just poll the crowd and really get a handle on what decisions people are making. You can use it for peer comparison to try to get a sense of where the progressive prescribers are, where the resistors are, and people who might not be ready to change, and then just have helpful dialogue with these groups and hopefully make some progress. Next slide. So we're a little behind, so I'm going to push through this really quickly. This just shows, stay on the side for 1 second, Kristen. So this just shows some of the progress that we made during the OASCN Collaborative. And this, in summary, what this shows is a well-appearing newborn baby. And we asked if people wanted to order a CRP. And then we asked if they would start antibiotics if the CRP went from 18 to 56. And in summary, this shows the improvement in how people changed over time in those antibiotic decisions. Next slide. So if you have your phone, take out your phone and just snap a quick picture of this. So this is basically a description of the results of that case that I just showed. It may be helpful for some of you who may be struggling in this space to use this and actually walk through this vignette with colleagues. The hourglass shows the likelihood of each prescriber to choose a specific decision, as you can see there, and each one of the blue dots is an individual. So you can use this and walk through this with your colleagues and have a discussion about why they chose, what they did, and hopefully make some progress with this. Next slide. Okay, and then number 3. We saw a lot of sites during the collaborative figure out that a lot of the things that they were doing may not be beneficial for stewardship. So we're talking about de-implementing some old practices. And this gets at, how useful is the CRP? How useful is the CBC and procalcitonin? And what we saw in the vignettes, people were ordering these inflammatory markers, and then they ended up using them in a way that we didn't intend for them. They ended up using more antibiotics by ordering these tests. There's a great video that Bill Bennett does in the resources that kind of touches on this. And lastly, as I finish up, so this control chart shows a single site. This is actually data from Cedars NICU. And what it shows is CRP use over time. So a good example of a NICU having success with de-implementing some of these old practices. So next slide. Okay, so to wrap up here, so 3 lessons. Innovate with measuring. Keep in mind, hopefully you can find someone in your NICU who's interested in creating these control charts. It's ridiculously easy to do, but it's a very powerful tool. You can make very lo-fi case vignettes to try to understand prescribing practices among the folks who are prescribing antibiotics in your NICU. And then, like I touched on, consider de-implementing some of these old practices. And I put 2 links to 2 videos that go a little bit more in depth into some of these topics that I just discussed here on this slide. And I think we have the learning point. So I think you all know the resource bundle has 47 learning points. These learning points basically came from all of these discussions, figuring out what was important to all the NICUs, and all of these are available. These are 13 learning points that we pulled out that people thought were very important. And with that, I think we'll turn it over to Ken, and Ken is going to walk us through these resources online and help you figure out how to access them.
Great. Thank you, Carlin. Can you all see my sort of Google search here? Is that visible?
Yeah.
Okay.
We just saw it. It disappeared, but I could see it a second ago.
Oh, really?
Can others see it now?
Is anybody seeing it?
I cannot see it right now.
Cannot see it. Let me try again.
No.
Okay. That's unfortunate. Let me try again here. Hold on. Let's share my screen. And let's pick it and share it. Do you see it now?
Yes.
You do. Excellent. Okay. So, pardon my head turning. I got to look on this computer. I think putting it on this screen screwed it up last time. So, Henry and Carlin, everyone sort of noted that we have this collaborative, and that's fantastic. And then there's a bunch of units in the state that weren't part of the collaborative, but they're part of CPQCC. And then there's other sites that aren't part of either. And it's great. The information was transmitted. Peter showed you some results. Carlin showed you some results, and that's great. And those of you that participated in it won't forget it, we hope. But the larger goal, of course, is just to disseminate to others or to make permanent some of the resources that were generated by us as a group. So we've, just so people know, there's one publication from these data. There are several in process. The website that I want to go through in the resource bundle is the more permanent location of resources for everybody. So you can see on my screen, I just Googled CPQCC stewardship. You can do CPQCC antibiotic stewardship. You can do CPQCC OASCN, if you actually know that acronym. And you'll notice in every instance, the top one is OASCN. So I'm going to click on OASCN. Did that? I hope that scrolled. Do you see the website now? Yes?
Yeah.
Okay.
Yes, we see.
So fantastic. So any way you Google it, you'll get there. It's the top thing. I'm just going to take a few minutes to walk you through this. I'm not going to read all this to you. This is the landing page for the OASCN Collaborative, why we care, our approach, benefits, and a bunch of names and centers, which is you all and others. That's great. I just will tell you, some of the slides you've already seen are actually, if you click here, you get to the slide that Peter showed you. If you click here, you get top 10 learning points instead of 13, but there you go. And if you click here, you get OASCN by the numbers, which Peter also showed you, just FYI. But the meat of this thing, I think, if you go on the page, and right here it says OASCN Resource Bundle. So you click on that, and you get to this. And what we tried to do here is provide a lot of information for you so that you have the opportunity to pick and choose what you want. Again, I'm not going to read any English here. I'm just going to show you. By the way, if you click on this hyperlink, just to tell you, it goes right back to where we were. We try to make it as user-friendly as possible. So let's go back to the bundle. Over here are OASCN learning points. Carlin just said there were 47 points developed. If you click on that, you get the list of general topics that we've broken this down by. We talked about lots of stuff that many of you know who participated in the collaborative. Here they are, all of them. And this is just the number of learning points that was generated by topic. So let's just pick one randomly. Early onset sepsis. So here's early onset sepsis. Here, number 10, 11, there's 5 learning points here that you can read for yourself. Oh, isn't that interesting? Let's go back. What other topics do they have? Back to learning points. Well, I happen to have a particular interest in syphilis because I see all kinds of rule out congenital syphilis. What does that have to do with antibiotic stewardship? Click on syphilis, and here it is, syphilis. 2 specific learning points. So every learning point for all of these topics are readily accessible a click away. And of course, you can share them with anybody you want. That's the learning points. We have references. Click on the reference list, same topics. Same topics. You want the references for the early onset sepsis management, let's say? Here they are. And I think every single one of them has been hyperlinked, if I click on that, to a PubMed search. And then you can acquire the paper any way that you're used to doing once you get to PubMed. I've also, let's just go back to some random thing here, fungal sepsis. Several of these are, almost all of them are annotated. Mainly Carlin and I sort of looked at this paper, and we just try to put in English for you what value it might have. Oh, this is a meta-analysis of all randomized control topics on the top, trials on the topic. Or look, this is from Canada and blah, blah, blah. So we try to put some context to this. You can always click on the hyperlink and go to the abstract and see for yourself, but we try to simplify it a little bit for you. So that's learning points and stewardship reference list. If we scroll down a little bit to topics, these are all the exact same topics. We try to make it very simple for everybody, and click on herpes or something, and you get to this. Here are the learning points. Okay, let me go to a different topic that might have, let's go to early onset sepsis management. Okay. Here are the learning points, which you can get through the other method. But importantly up here, for those sessions for which there was a little 10 or 15-minute didactic, you'll see it right here. So here, this is under early onset sepsis management, use of inflammatory markers for evaluating early and late onset disease. Bill Bennett's, who gave it. He's one of our faculty panel members. Here are the slides. You click on the slides. Boom, there are the slides. Feel free to steal them and use them and disseminate. No problem. Oops, go back. There's even a video. I'm not going to click on the video, but there's a video of the session, Bill giving the talk. There are other, we've tried to get any topic or didactic or video that was relevant to the early, in this case, early onset sepsis management, and put it here for you. Antibacterial drugs by our stellar pharmacist here, Jason Sabaron, who was on our faculty panel. Here are his slides. Duration of therapy, here's my slides. Antimicrobial stewardship for preterms, here's Bill's slides. So again, for every topic, we're trying to find all the relevant, this is just stewardship in the NICU, all the relevant talks and videos for you to access and steal at your leisure. And here are the learning points again. So that's pretty much it. References, learning points, slides, videos, and all of that for every subject topic. And if you don't know the topic, again, you could just click and down here, and here are all the topics. And I think that's it. Is there anything, anybody, Peter or Carolyn or Henry, anybody wants to say about the bundle?
I think that's good. We're doing okay on time. If anyone wants to ask a question about the bundle, we will get ready to move on to our participant sites.
Oh, can I add one other thing? If anybody gets on the bundle and they see something that's egregiously wrong, please let us know, and we'll do our best to fix it. We've certainly spent hours and hours trying to make it up to date and perfect, but fresh eyes are always a good thing.
Okay, great. Thanks, Ken. So, as Henry touched on, the magic happens once we start bringing sites together and we are having a dialogue and kind of sharing best practices. So we're going to do a little bit of that now. We're going to start with Faye Velosis from Kaiser Panorama City. She's a neonatologist that many of you know, and they were known for having a very low AUR during the collaborative. So we asked a few questions, and Faye's going to touch on those. Next slide. So Faye, if you want to unmute, we wanted to briefly hear you talk about your top 1 to 2 successes during OASCN.
Yes, thank you for this invitation. So basically, we just make it so simple because when we were invited, we want to be straightforward to make a difference of 20% reduction in their AUR. So we basically just went to go to 36-hour with negative blood cultures. And the second thing we did was to be compliant to the algorithm that we created as a group and be to follow that. Next slide. So this is basically an algorithm which will actually modify this based on the published by Popolo regarding the maternal symptoms and the baby symptoms. But we added another layer in this RESPA, which is the respiratory symptoms, which most babies, majority of them that comes to NICU with respiratory distress. So if you're going to qualify that as a symptom for sepsis, then all babies will be on antibiotic exposure. So we eliminated and stratified it to make sure the baby is well looking, doesn't have to always be under risk because of just respiratory alone. So that was actually one of the success of this algorithm, that we added another layer of respiratory distress, not to point respiratory distress as a symptom for to place a baby for infection or exposure to antibiotics. I think that's one of our success in this algorithm. And this one is really, we were so impressed with this, just joined the collaborative. We didn't expect to get a 20% reduction because we're already low. To begin with, our pre-intervention was 8% before the collaborative. we went down by 6.4% for the total AUR, and that's 20% reduction. And even post the OASCN Collaborative this year, we're even down to 5.5. That's almost 31% from our baseline. And our antibiotic exposure is almost 50% reduction from our baseline, from 6% to 3.2%. This is such amazing that we never expect to come to this low number. So, and of course, it was really a lot of learnings from the collaborative that I can't overemphasize, that without being in this club, we could have not made this being open-minded to change and make a difference in many ways. So, and again, changing the mindset and really the buy-in from the physician, almost 100% was really a crucial part of the success of our reduction. So thank you for the OASCN.
Great, thanks, Faye. I think we're doing okay on time. I just want to ask you a question that I'll probably hit the other participants with who are presenting. There was a question that came in: sustainability is difficult for any QI project. How has monitoring continued for AUR for participating units and on your own unit? So Faye, do you want to touch on that? How are you monitoring AUR moving forward?
So even after the collaborative, we continue the lab QI because it's important for me to look at our data month to month, because without the data, we'll not be able to know how we're doing. So I continue to do that and keep giving the feedback almost in a monthly basis to my team, to our physicians. And really, we're looking into mostly how, because we have new physicians in our group, to make sure that they're in compliance to the algorithm. So it's like really, we audit every case that's not make sense in the exposure. So really, this was an intentional sustainability that we have in our unit for this year. So really, we're so impressed with this work, because it's not just a matter of following the compliance of everyone, but really there was a real buy-in for the entire team in the NICU.
Great, thanks a lot, Faye. So we're going to move on to Sina Halayan, who's one of the neonatologists at Cedars who led our stewardship work. And she's going to start off by talking about a couple of our successes. Go ahead, Sina.
Hi, everyone. Can you hear me okay?
Loud and clear.
Okay, great. Again, thank you. Thank you for the opportunity to present some of this here today. Again, I'm from Cedars-Sinai, and we were involved in both of the years of the OASCN Collaborative. And two of our sort of major successes, and I'll talk about this a little bit more in the subsequent slides, but essentially we figured out a new approach, or a different approach to the most commonly used antibiotic metric, at least in the state of California, the AUR, again, the antibiotic utilization rate. And what we were seeing early on in the collaborative is that despite being involved and having implemented some of the changes, we weren't really seeing significant changes in the AUR. And again, I'll show that to you in a chart in a couple of slides. But by stratifying the AUR by gestational age, and then also by looking at the first week of life, because our efforts were primarily early onset sepsis, by looking at the first week of life AUR, all of a sudden we saw small but significant changes to our antibiotic use. And so we were able to reduce our AUR in both the bigger babies, 35 weeks and over, and smaller babies of less than 35 weeks by at least 20% in the first week of life. Next slide. So these are the two guidelines that we developed and implemented, and the details of the guidelines aren't important, but essentially the goal was to reduce antibiotic use for the infants greater than 35 weeks, which we focused on the first year during the OASCN Collaborative, and then the second year we focused more on the smaller babies less than 35 weeks. The guidelines are evidence-based and largely sort of guided by the 2018 American Academy of Pediatrics recommendations, but tweaked to sort of fit our practices over at Cedars-Sinai. And part of these guidelines was also the laboratory workup, and Kerlin went over that earlier. We were able to reduce our CRP usage as well. Some of the additional tools that we used were case vignettes, and we implemented 36-hour timeouts into our Epic. Updated our note templates to include sort of the risk criteria, and started to do nursing rounds to try to really involve our nurses in antibiotic decision making as well, particularly for the bigger babies, where we implemented serial nursing assessments. Next slide. So here you could see on the left is our monthly P chart looking at all gestational age, unstratified, a monthly AUR. And despite the start date is 2 years prior to OCEAN, and then you could see the CPQCC start date, and then when we implemented the big and small baby guidelines, and really no significant change in our AUR was detected. And then we thought to stratify by gestational age and by the first week of life, again, because we focused on early onset sepsis. And so when we looked at just the first 7 days, that's what the F7D acronym stands for. All of a sudden now you can see 12 consecutive months of special cause variation. We were able to shift our center line down and a total 23% reduction in our AUR. And this is for all babies. So then we stratified by gestational age, which made sense for our unit because we had different processes and different guidelines for the two. And so if you look at the big baby, if you hit next slide, it should pop up. Yep. So again, the chart on the left shows the monthly AUR. We see a few months of improvement, but it was not sustained. And so we weren't able to shift our center line. But again, when we looked at the first 7 days, we had 13 consecutive months of improvement with a 30% reduction in our AUR. Similarly, in the smaller babies, next slide, you'll see on the left, not surprisingly, no change at all. Which, if you think about how AUR is defined, it really makes sense, right? Because preterm babies have prolonged stays, so the denominator is large, and hence it dilutes down your proportion, your AUR. And so no change there despite all our efforts. And again, when we look at the first 7 days, we've got 9 consecutive months of improvement with 27% reduction in our AUR. Next slide. So we have been able to sustain these improvements. Some of you may have actually heard me give this a similar talk over at CAN, but we're excited to announce that the work was recently accepted into the Journal of Perinatology. And so top sort of couple of lessons, of course, you know, I second what Faye was saying, but sort of more unique to our unit. We encourage other units to look at, stratifying the AUR or approaching it in whatever way makes sense for your unit. This was actually also demonstrated by Dr. Flannery in a paper in 2021, where he showed that patient-level characteristics such as gestational age and gender actually are independently associated with AUR. And so really one size does not fit all. And then one of the other lessons is just to, preterm and term babies are such distinct entities. You guys all know that. And so to consider separating the processes for antibiotic stewardship for these two populations. I think that's all I had. Thank you again for letting me share this with you.
Great. Thanks a lot, Sina. So really quickly, kind of similar question that I asked before. We tend to beat people over the head with our monthly AUR, but you've done a good job setting up a kind of system with the nurse practitioners, even digging down into this. You want to just talk briefly about kind of how you think about monitoring and reacting to blips on the radar with the AUR?
Yeah, so we, it's funny, we actually turned our OCEAN group into, what we now call the NICU infection task force. And so we continue to meet monthly. We continue to review the data. Carlin's my boss. So I have a, good colleague for that. And so we present our AUR monthly at a collaborative meeting that involves nursing. And so if we see any blips in data, we do in-depth chart reviews. And so, we've been able to sustain our improvements and are sort of thinking about extending this into more late onset sepsis work as well moving forward.
Great, thanks. Okay, so Kathy Weiss. So Kathy is one of the neonatologists at Rady Rancho Springs, and she's done some interesting things with multidisciplinary kind of collaboration around blood cultures. So looking forward to hear from Kathy.
Hey, good afternoon. So yeah, we're from Rady Satellite in Rancho Springs. That's about an hour north of San Diego, and it's about 13-bed unit. And so we were very excited to be part of this collaborative. And we felt like our top two successes were the creation of the early onset sepsis guideline, like you guys saw with Faye and Sina kind of talking about theirs. And then the other thing was the blood culture, which we had a couple of talks, or actually many talks on blood culture during the OASCN Collaborative. And I think one of our realizations was the importance of the 1 ml was the big thing there. We found when we were talking to our nurses about this and best ways to optimize it, that some of them were only drawing until where the blood culture became pink and not the full ml. And so we realized that our blood culture were not as optimal as they should have been. And so I think that was a great learning point that came from this collaborative, as well as many of the other different ways that you can optimize your blood culture to make sure that you can fully trust it, because we were putting a lot of trust in the blood culture as well as the clinical status from what we learned in this collaborative. Next slide. So here, kind of to the right, is the tool that we created, or part of it. And like many of the others, we somewhat stratified our tools. And right now, we just have greater than 35 weeks in the first 72 hours of life as our early onset sepsis guidelines, with the hope in the coming year to go to less than 35 weeks. Some of the things we focused on were the treatment courses. So doing a 36-hour rule out, like many of the other ones did, a 5-day culture negative, as well as congenital pneumonia sepsis treatment. And then Dr. Shulman, I know was mentioned before, and he kind of spoke to ruling in the diagnosis. So that became a really important part of our talking and learning in this collaborative, as well as what we put in our early onset sepsis guidelines, to not just think about ruling out sepsis, to rule in what else was going on. So, when you have a baby who's maybe a scheduled C-section or precipitous delivery, and you think more likely TTN, and that maybe you can just watch the respiratory distress early on without first using antibiotics. And we also looked at things like if the baby had meconium, maybe we could watch. So again, I think it was just being able to watch and wait and think about maybe what was causing your tachypnea or respiratory distress before automatically starting antibiotics and assuming it was sepsis. And then again, the blood culture. And our nurses had listened to some of the talks on that. They came up with their own pearls. We came up with a whole blood culture pearl sheet as part of this also early onset sepsis guideline. And again, we just want to make sure that when we get that blood culture, we trust it. And one of the things we've done is if we can't draw 1 ml blood culture, they're supposed to document or let one of the providers know. So that way, if for some reason we're unable to draw it from the vein, we can try to figure out other ways to optimize our blood culture at the time of drawing it. Next slide. So sustaining improvements. So yes and no. So, it's interesting talking about the stratification, because many of the others have mentioned it. And we had the greater than 35 week and less than 35 week AUR. And the top one that you saw there was the less than 35 weeks. And early on in the first year, we didn't really see a drop. But with the second year, the sustainability phase, I think we got more used to hearing about antibiotic stewardship. And we saw that drop in the less than 35 weeks, because I think we became more comfortable with less use of antibiotics and seeing that babies did okay, and that we could visualize and watch them clinically and then start them if need be. And that's actually been more sustained. The one that started lower early in the first year and got to about like 6% was our greater than 35 weeks. And then kind of in the past year, even though we've done this early onset sepsis guideline, has gone up a little bit. And I think it's very important talking about stratifying, like I know Sina mentioned, because what we found is that in this past summer, especially with COVID now going down, we're admitting a lot more babies for late onset sepsis than we did before. And that's really driving up our antibiotic rate, especially after the first few weeks of life. So we're actually looking in the process right now, trying to stratify that and see if we can kind of weasel out the early onset versus the late onset sepsis and kind of try to look at those two entities themselves. But we do feel like early onset sepsis overall, we've got a better handle on, and the new providers coming in have created some re-education to also create that early onset sepsis guideline or get more sustainability with it. But as we re-educate, we're finding that it goes back down again. So again, just kind of some of the things that sustainability entails. Top 1 to 3 lessons, various ways to implement antibiotic stewardship based on your NICU size and staff. And some of them have mentioned them, like hard stops, electronic medical record use, implementing it into there, talking to your nurses and having nursing champions as well as provider champions. We focused on the blood culture and clinical status and tried to put less emphasis on things like CRP and CBC. And then the last lesson was, what you do is less important than how carefully you pay attention to the consequences. And I think that was a Dr. Bennett's quote, and very true in that, if you elect not use antibiotics, know that you can just follow that clinical status after, or if you're doing a QI project on antibiotic stewardship, maybe an important balancing measure is to have follow-up of late onset sepsis later on in the course, or follow-up of readmissions. And that's what we did in our QI collaborative. And I think it can help you overall with your antibiotic stewardship.
Great. Thanks, Kathy. So similar question for you. Anything to add about what you might think would be beneficial for others to hear about how you're doing continuous monitoring and kind of responding?
Yeah. So again, somewhat spoke to it, but I think a big part of it is we already had built in the AUR measurements. So we're able to continuously get that monthly, and then we're able to evaluate it. And that's how we kind of recently realized the increase in the late onset sepsis antibiotic use and looking at that. So that's causing us to again stratify and relook at that, as well as we can kind of monitor where our use of antibiotics is. And we've again noticed we've had some new providers come into our unit, and some of them hadn't been as educated on the late onset sepsis protocol. So realizing that we just needed to do a better job of re-education. And so I think that's a big part of sustainability, is that's change is constant. So making sure that you keep on top of that.
Great. Well, thanks everybody for putting this info together. I hope this was helpful for the sites that we're on. It was helpful for me, even though I've heard some of this before. Okay, so there were questions that were submitted to us for the group and from the group. And so if people have other questions, please chat them in. We will kind of start to wrap up by going through some of these questions, some of which we may have already touched on. Maybe Ken, if you want to speak to this first one, AMP and GENT versus AMP and cefotax for empiric early onset sepsis treatment.
Yeah, so that's a good question. I would just make the comment that cefotaxime isn't really manufactured in this country anymore. Now, maybe you're one of the units that's able to get it from Canada, which happens sometimes on the East Coast, but in general, it's not available. So people have moved to either aminoglycoside like GENT or cefepime / ceftazidime, mainly cefepime, which is a cephalosporin that also has anti-pseudomonal coverage. So just to set the table a little bit there. So we're generally prefer using the narrowest spectrum drugs, right, for the shortest periods of time. GENT being a little more narrow than cefepime, certainly, and probably a little more narrow than ceftriaxone, which would be the other opportunity, or the other alternative. There's a thing out there about the use of ceftriaxone and the possibility of displacing bilirubin and causing hyperbilirubinemia. That's another lecture in and of itself, but that's probably not, it's not a big deal. It's never been shown to cause kernicterus. It does displace bilirubin, but not to particularly high levels, and that was based on data from several decades ago. Another story, there's some stuff in the resource bundle about that, by the way. But anyway, so AMP and GENT is preferred because it's narrower spectrum, safe to do with monitoring, and that's the main reason. And you don't need cefepime because you don't need Pseudomonas. So I hope that covers the main topics quickly. And I will say there's a slide deck. Jason Sabron from our faculty panel did a whole talk on antimicrobial management, empiric use, talks about all the usage, all the stuff I just mentioned, and other things that might be worthwhile for you.
Great. I think we touched on the 36-hour piece already. Length of antibiotic therapy, if culture negative. I think the summary is that many sites are okay doing 5 days with the study that started with the SCOUT study with J.B. Canty's group. And I think during the OASCN Collaborative, a lot more were going over to, trying to use 5 days.
Well, Colonel, if I could just add one thing to that. In the context of pneumonia, where you diagnose pneumonia, 5 days is that was the SCOUT study's limit. But I will just remind everyone that if you have all the information that we bring together to make a decision about sepsis and the caveats on the use of the biomarkers, and you have negative cultures, and as was just mentioned by Dr. Weiss, getting the appropriate volume, and you're 36 to 48 hours in, and your risk factor profile is good, you can stop and comfortably and safely. Just to throw that out there.
Yep. Great. And then a question, ideal way to collect culture and what is better, venous or arterial? So Ken, I'll pitch this one to you. And then, but I do want people to know that Peter just put a link in for the paper that Linda Lafrac took the lead on and published that has a lot of helpful information from a nursing perspective. And
Curlin,
about
Linda's on. If you,
can you not hear me?
You're good.
Can you hear me now?
You're better now. Yeah, you're better.
Oh, okay. Yeah, I was just letting people know that that Peter put this link into the chat for this blood culture paper that everybody should take a look at. Linda Lafrac.
Yeah,
Linda's on
with
if you
other
want
others.
to ask.
So
is Linda on? Okay, so Linda, let's hear from you, but Ken, you want to touch on this venous arterial question?
oh, doesn't matter. Blood is blood. So as long as the key thing is volume, that's all. That's the main thing. Volume.
Okay, so
I am on the call.
Hey, Linda.
I'm by a noisy. I'm on the call. I'm by a noisy freeway, but yeah, there's no preference to venous or arterial. I think the most important things are volume, as Ken said, and good skin asepsis, and also just taking a look at your practices to make sure that your staff are practicing good technique when they're collecting a sample, and you're reducing the risk of contamination. But the article sort of goes into more detail, but I think volume, good skin asepsis, and just making sure that people's technique is good. Those would be my top three. But read the article. Hopefully it will guide you if you have questions, additional questions.
Great. Thanks, Linda. Very Southern California kind of response there with the highway in the background, but I think we heard most of it. And Linda has a great talk. I think Peter, Linda's talk, I think is on the resource bundle where she talks about very practical blood culture.
The paper,
processes.
I don't know if the talk is. If it isn't, we should post it.
Okay. Yeah. Okay. So the sustainability piece we touched on already. Trends in practice. Who is responsible for assessing and utilizing sepsis calculator in the NICU and mother-baby unit? I can say that Allison Henry, who's the director of our nursery, just kind of transitioned to a process that the nurses are doing that. And Kathy, I think you do that at your site. Is that right?
Yeah, we do. It was actually started, I think, with one of almost the former collaboratives, and the nurses do it on the newborn site, and they're trained by the women's services or nurses out there.
And I would throw out that in for those of you that have residents floating around or fellows, at least at our place, they do it, and it's a great learning experience on top of just direct clinical management, because they have to get into all the details of why it even exists and is it really valid and all that business.
Okay. And then there's a question, what adaptive challenges have you identified in implementing antibiotic policy in the NICU? And I'm not sure I completely understand that question, but if someone wants to kind of maybe add to that, either answer it or maybe clarify that question. And then will there be data shared with stakeholders regarding outcomes of this bundle? Again, I'm not quite sure how to answer that. The bundle is basically a repository of all the lessons from OASCN. As far as data from OASCN, there'll be multiple papers that are being published. But if whoever asked that question, if you want to clarify that, please.
Yeah, Curlin, could I sometimes when people talk about a bundle, it's a very discrete bundle of practices that you do clinically, let's say for CLABSI, putting in central meetings and stuff. As you said, our bundle is more just kind of a name for our resources that were generated in a collaborative that are put on the site. But we will have all of the implementation and outcomes results. Those will be published.
I wonder, Curlin, if the previous question was about asking the folks that presented, our panel folks, about challenges to buy-in, maybe that's what that meant, to get the various guidelines. Maybe the panelists have something to say about how hard it was or wasn't to get folks to buy in to what the goals were.
Yeah, no, that's a good one. Anybody want to jump on that?
I think, yeah, and I kind of didn't mention it, but again, this was like our second collaborative. So I think we kind of started with one many years before about use of CRP and had at that time started to talk to maybe less use of antibiotics, and it wasn't really accepted at that point. But now, having had this and the case vignettes and all the different experience from the NICUs and being able to share that in regular emails with our staff, I think throughout the year they got used to it, and that culture shift was a lot easier to change once we finally came out with the early onset sepsis guidelines and said, we've been through these learnings. This is what we've seen. Other NICUs are jumping on board, and it was a little bit easier for us to make that change to the 36-hour rule out and then the 5-day culture negative sepsis. Everyone jumped on board a little bit easier than before.
Yeah,
Great.
I agree with that. I think it just took a lot of repeated conversations and showing them, sort of the evidence and with the literature and that other NICUs are doing this, I think makes people feel more comfortable. But initially it was quite challenging. But
Great. Anything else?
Can I just push you a little bit on that? When you say challenging or quite challenging, I think was the word you said, were you concerned that it just wouldn't happen?
I was. I was. I think there's a lot of hesitancy in the beginning, especially with the preterm babies, and then also trying to reduce relapse to 36 hours. But once you put some hard stops in place and just again continued conversations, and you hear one or two of the other neos doing it, and then you start to do it, and it took a little bit of time, but there's still a little bit of hesitancy, but culture shifts are very challenging.
Yeah, I will say that there is a paper, it was Outpatient Pediatrics on Stewardship, where they found that peer comparison, so just people hearing about where they fall with their peers in terms of antibiotic use, actually helps with change. And that's one of the things you can do with the vignettes, just visually showing that someone's way over there on the side and everybody else is somewhere else. Okay, so we are running close on time. We've got 2 minutes, so let's move forward. Kristen, go ahead. I think we just got an evaluation slide for today. So again, the purpose of this was, to reach out and connect with all the sites that were not able to be in OASCN. At CPQCC, this is one of the goals of these collaboratives, is to disseminate all the lessons learned to those who weren't in the collaborative, and also hear and learn from those who weren't in the collaborative. So take a second, fill out this evaluation. Please put anything else in the chat. And Kristen or anybody else, anything else before we wrap up?
Well, I just want to say thank you to everyone who participated in, so many different ways, including today's webinar. And there too, in addition to, hopefully we want to get good feedback from you about this webinar, but also just related to anything that CPQCC can be doing to help you with your quality improvement efforts, both for antibiotic stewardship, but really for anything else as well. Could reach out to Courtney or go on the CPQCC website and go to the Contact Us page, where there's ways for you to sort of get support. Because really we are a learning community, and appreciate opportunities to hear about your challenges as well. And just a note that in the upcoming year, you'll hear about one of the next collaboratives will be on breast milk and nutrition, that will be specifically geared toward safety net hospitals and similar hospitals. So excited about that, but also open to your just suggestions too on what we can all be working on together. But thank you very much for participating. And please share this. You'll get an email about the recording of this webinar and all the resources for OASCN probably about a week from now.
Great. Thank you, everybody, for joining. Have a good rest of the day.
Yeah.
Take care.